Okay. All right, so let's get started. It's a few minutes after the hour. Welcome, everybody. I'm Joe Simonetti from the Firearm Injury Prevention Initiative at the University of Colorado Anschutz Medical Campus. Thank you for being here. So this is our webinar series where our goal is to spotlight novel, important efforts in the community, education, research, policy spheres that are advancing the state of firearm injury prevention in a variety of different contexts and populations. And in line with our approach here at the initiative, placing an emphasis on efforts that are collaborative or multidisciplinary in nature. With that in mind, I'm excited today to announce our two speakers, Kate Origer and Omar Norgaisse, who I'll leave the slide to in just a second here. But they'll be presenting today on their work in crisis outreach response and engagement in Longmont, Colorado. Kate Origer is a licensed social worker with the Longmont Department of Public Safety. Kate holds multiple roles in this department, including clinical case manager and acting clinician for the Crisis Outreach Response and Engagement Team, or the CORE team. As a clinician, she's responsible for responding to calls for service to offer clinical crisis intervention and de-escalation, alongside patrol officers, CORE police officers, and CORE paramedics. As a case manager, she's responsible for walking alongside clients with severe mental health conditions and helping them connect the resources necessary to accomplish their goals. Kate started with the Longmont Department of Public Safety as an intern in the Victim Services Unit through her social work education and chose to focus on mental health and trauma. Kate received her master's from the University of Denver Graduate School of Social Work. Also with us today, Omar Norgaisse is a paramedic with 27 years of pre-hospital and emergency service experience. Currently, he's a member of the Crisis Outreach Response and Engagement Team, or the CORE team, within the Longmont Department of Public Safety. His duties include crisis response, medical assessments and treatments, as well as resource coordination for the individuals the team interacts with. And in addition, Omar leads the community health program within the department and is a crisis negotiator with the Special Weapons and Tactics team. Prior to joining Longmont, he worked in 911 emergency medical service systems of New York City and Baton Rouge, which includes time as a hazmat paramedic. He taught as a skills instructor for Suffolk County EMS in New York, as well as an adjunct instructor at the Carol L. Herring Fire and Emergency Training Institute of Louisiana State University. In addition, Omar has worked non-traditional pre-hospital roles in the urban construction and industrial spaces. He also has an associate in psychology degree from the University of Phoenix. Omar and Kate, thank you very much for joining us today. And with that, I am going to leave the floor to you for your presentation. Thank you for being here.
Thank you for having us. So my name is Kate, like Joe just mentioned. I'm a social worker. I fill the role of clinical case manager and acting clinician on the CORE team with the Longmont Police Department. So let's share the screen. All right, can everybody see that okay? Okay.
Got it.
Perfect. So our department offers a pretty wide range of behavioral health supports for the community that we serve. We're in Longmont, Colorado. We have guiding principles for these different branches of the department that focus on harm reduction, officer discretion, community outreach, and cultivating individual relationships. In addition to our own team CORE, which we'll get into more as we go, we also have a program called LEAD, that stands for Law Enforcement Assisted Diversion. It was developed in July of 2018. What LEAD offers is intensive case management provided to individuals who are struggling with substance use. It comes through to our case management team. Participants of this program have to be referred by patrol. So a police officer has to engage with the participant to determine that they are an appropriate referral and then send them through to our case management. This can be done in order to divert charges from individuals who are contacted for substance use related concerns. The Angel Initiative is very similar. These referrals go through to the same team of case managers who work with the police department. This is also for individuals who are struggling with substance use, but it's focused more on treatment. And these can come from the person themselves. They can come into the police department, request to apply to the Angel Initiative, and be routed directly through to our case management team for very similar intensive case management services for the same purpose of moving away from substance use. Community health is our medical-based program. Omar may be able to speak to this one a little bit better than I can. It's also connected to the same case management team, and it's rooted in minimizing the risk of frequent admission to emergency departments for medical care. It allows medical professionals and case management to bring care to individuals in the community. Started in April of 2019, can sometimes involve deliberate medical outreach on the streets. Every other Thursday at this point in the year, we have a nurse practitioner and a case manager going out into the community to engage individuals who may need medical care on the streets, who may have difficulty getting to a medical facility. And it also offers outreach to folks who are overutilizing emergency departments to see what can be done to break that cycle or find something new that doesn't involve consistency of emergency department utilization. And then there's CORE. We are the mental health related team. We were founded in the form that we have now in March of 2018, stand for Crisis Outreach Response and Engagement. We are a multidisciplinary team that's made up of a dedicated police officer, a mental health clinician, and a paramedic. We offer primary response by intervening in 911 calls for service that have to do with mental health related crises or sometimes substance use. We can intervene in those calls as well. We will offer de-escalation, crisis intervention, resource navigation, and we follow up with the folks that we engage with in a crisis capacity. If somebody is, for example, if somebody is brought to the hospital in a mental health hold for suicidality, we will help with that process. We will get them brought to the hospital safely, and then we'll follow up with them and we'll see how they're doing after they're released from the hospital. We'll get them connected to additional resources as needed for long-term stability. Our primary goals for what we try to accomplish as our team: we do crisis response, we'll assess people on scene, we will offer resource navigation, continual outreach, and build relationships with people to help them get into a better, more stable place moving forward.
Thanks, Kate. So why a co-responder team? And by the way, as Joe introduced, my name's Omar Norgaisse. I'm a paramedic on the co-responder team here in Longmont. So why a co-responder team? Well, this allows us to share responsibility with patrol, with placing individuals on M1 holds if it's indicated, being able to participate in the de-escalation process, with our officers being able to go hands-on with individuals if it's indicated. I can tell you most of the time we don't need to do that. We're able to safely plan with folks, de-escalate folks to the point where that's not necessary, and gain cooperation where individuals want to seek assistance. Another thing that we do is that we try to break down historical barriers and perceptions that exist between those who have mental health conditions and the police. When people in uniform show up, it shouldn't be the idea that you're in trouble or you're going to be taken away. It's, hey, we're here to help. Let's figure out a game plan as to how we can help you and what that help looks like. Whether it is you being able to connect with a provider while you're at home, whether it is resource coordination, where we connect you with someone who can help you with whatever it is that's kind of underpinning your struggle at this point in time, or if it means that you do have to go somewhere, let's kind of get a game plan as to where that is and what that looks like, and make sure that everybody's well informed throughout that process. Ultimately, our goal as far as being able to support not just the patrol division, but as the fire division and all the divisions within the department and the city at large, is to reduce calls from high utilizers. We want people to be able to feel empowered to reach out to resources. That does not necessarily mean that they have to pick up a phone and call 911. Now, that doesn't mean that they shouldn't call 911. if they have an emergency, absolutely call 911 and have somebody respond and, figure out what's going on. But if there are other resources that can be helpful for that person, let's find out what those resources are and connect them to that and reduce their reliance on 911 as a solution to their problems. We're all subject matter experts. If Kate's there, she is the mental health subject matter expert. If I'm there, I'm the medical subject matter expert. And if our officers there, they are the law enforcement and safety subject matter expert. So as I mentioned, we try to navigate resources, not just for the individuals that we contact, but for the individuals that have referred that person. So whether it's a patrol officer, whether it's a firefighter or a paramedic, whether it is another member of the city government who had some concern about somebody, we try to figure out what resources everybody needs to know about and what will best help that person. Ultimately, we want to improve job satisfaction for patrol. We don't want people to feel that they're going to the same calls over and over again and that there are no resources or outlets for them to reach out to so that they can get people that they contact connected to help. We want to, and we do work on our community relationships so that when we drive down the street or when we show up somewhere, a lot of organizations, a lot of businesses know who we are and they freely interact with us. They'll reach out to us and say, hey, there's this guy that I know that is really struggling. He's always here before noon. If you guys can kind of sit down and talk to him and kind of figure out what he needs and, see which direction you can point him into, which is great because at the point that we're at right now, we can pretty much be reached out by anyone in the community to kind of plug us into people and get them plugged into things. And one of the bigger things, which is why I really like the way our team is formulated, is that we're able to open up communication between different disciplines. I can speak to the medical providers at a doctor's office, at a hospital. Our clinicians can speak to people in the social work and the counseling world. Our officers can speak to other law enforcement agencies, to kind of coordinate information and help services. Back to you, Kate.
Thank you. So as Omar touched on in that last slide, we exist to fill these roles and fill this gap in many communities by addressing the need where it's at. So we will bring the right services to the right locations at the right time. So if that's crisis intervention, that's one way we can do that. If that is being aware of the struggles that a person is experiencing and being aware that they've been brought to the hospital, we can have that conversation with the staff at the hospital, whether it be the medical side or the social work department. We provide service where the crisis occurs to all ages. Right now, part of our team is at an elementary or a middle school, I believe, engaging with a younger individual who's having a rough day. We have worked with people in all ages, in all walks of life. We've gone to assisted living communities. We've gone to schools. Age is not a barrier to the services that we can provide. We work on decreasing utilization of emergency departments and jails. We try to divert people from going to the hospital, going to jail, specifically when it comes to a mental health emergency, because we know that those are not necessarily the best places for somebody who's experiencing an acute mental health crisis. We can help to ensure the physical and mental safety of a person on scene with our paramedics being on hand. We've gone to calls that we expect to be a mental health related crisis. And when we get there, it turns out that there's something medical going on, and having a paramedic on our team with us all the time helps us be able to intervene in the most effective way in that moment. We are able to support police department, the fire department, and our hospitals through this work. We are able to, by being out in the community, already on the move, being aware of the population that we are working with, having these relationships built in with the members of our community allows us to effectively create responsiveness in our community and the ability to walk into just about any kind of situation and hopefully navigate the situation in a way that will be beneficial for the community members and the partnering agencies that may also be involved with that person. All right, Omar.
Thanks, Kate. So, as we've stated multiple times, we're made up of an officer, clinician, and paramedic. This trifecta allows us to bring a bevy of resources and abilities to a person's side and meet them where they're at in the community. A big part of what we do is the crisis de-escalation piece and the follow-up piece, especially. We try to make sure that people understand we're not the M1 squad. We're not there to show up and grab people and take them away. We want to be able to kind of mitigate what's going on in the moment, and the ultimate or best outcome would be for this person to be safe at home and kind of have a safety plan in place as to, you know, what they're going to do for the rest of that day and who they need to get connected to over the next few days. And we follow up with them to see if they were able to connect to services, if they were able to connect to a provider, if they were able to engage in those activities that they needed to engage in, so that they can kind of find a better resolution to whatever was going on, whether it's whether it's an episode of mania, whether it's suicidal ideation, whether it's general depression. We try to provide people with tools that they can use, but they also have to be able to choose to use those tools as well. I'm a big fan of saying, you know, I can lead a horse to water, but I can't make him drink, right? So when someone is struggling and they want help, I will lay out everything I can, and I will offer you all the information that I can, but that person has to take it upon themselves to be able to actually engage in some steps to be able to engage with that help, whatever that looks like. In triaging folks, one thing that's really interesting, and Kate kind of mentioned this, especially when, you know, it gets dispatched as a mental health call for service, and then we show up and there's a medical presentation. Something a lot of people don't realize is that there are a number of medical presentations that present as a mental health presentation. So someone who is what we in the medical world call an altered mental state, may exhibit some psychotic behaviors, may not be aware of where they are or who they are or what's going on around them. This could be caused by low blood sugar or hypoglycemia. It could be caused by physical trauma to the head, or it could be an organic injury to the head where there's a pre-existing or congenital issue that causes them to not be able to focus in the moment or have complete awareness of what's going on around them. Strokes can cause somebody to slowly start to lose their level of alertness and change their level of consciousness to an extent. And then the damage progressively gets worse if it doesn't get treated. And a big one that we kind of hear, especially in the elderly population, would be urinary tract infections. Over time, that can become systemic and will cause people to have an altered mental status as a result if it goes untreated, and it can ultimately lead to sepsis, lead to death if it doesn't get treated. So these are things that having a medical provider on the team allows the team to identify. These are factors that are impacting this person's presentation or behaviors, and then start the mitigation process, or at least identify that this person needs a higher level of care in the medical realm and address those concerns in the medical space before we start looking at, other underlying issues that are going on. So this improves outcomes, improves safety, improves health for everybody. Another thing that we're able to do as a team with all three disciplines is assess for whether or not this person would qualify for direct admit to a specific 2765 facility. So what we're able to do is do a field assessment, both on the behavioral health clinical side as well as the medical clinical side. And we can determine if this person's appropriate by ensuring that this person meets certain parameters that each facility that we have agreements with provide us with. Make sure that their blood pressure is within a certain range, that there are no pre-existing conditions that would exclude them from being able to directly transport it there. Making sure that there are no acute presentations or any life threats that are present that would impact this person's ability to be successful in that space. Once we're able to screen all that out, we communicate with the facility ensure that this person would be a good fit for them. And we go ahead and we will transport them there. A lot of times, again, this falls within that voluntary transport realm where we kind of work with people to kind of, identify, hey, you need help to kind of get to a better place. And a lot of times this works very well in our favor where we're able to get people to those facilities where they're not too high of an acuity and not requiring further medical assessment in an emergency department. So places that we can take people to include walk-in centers. We have walk-in center at Boulder. We have one in Firestone. Yeah. We have access to North Range in Greeley. And we also have access to All Health down in, Littleton, if we need to. So we try to have as many resources available as possible so that people have options to go where they feel comfortable and where they believe they'll get good care. As Kate mentioned, we do try to do our best to divert folks from a hold or jail when appropriate. There are times where, the criminal aspect may outweigh any other presentation that's going on, and that needs to be addressed. Again, the officers have to give weight to what's going on and how that will impact their situation. And again, we really love to talk about the follow-up aspect, especially when we're talking about connecting people to resources. So being able to go back a few days later or a week later and kind of see where they're at when they're stable at baseline and, they're doing well and they're able to have, not that they would have a bad interaction with us, but they're able to have a better interaction because they're more with it, for lack of a better term, in that moment. They're safer, they feel stable, they feel better, so they're able to have a more meaningful conversation about their circumstances and what's going on and how resources that we provided have helped them. Okay.
All right. So with the foundation being laid of what we do, when the most appropriate time to contact CORE is if it's related to behavioral health concern, or even if you're not sure, this mostly applies to our partners in patrol. However, like Omar mentioned earlier, there are community partner agencies that contact us. There are hospitals that will call us to weigh in on something. If, say, we've got a couple of officers out on a scene with somebody who begins to present as though they may have some underlying mental health condition, frequently they'll call us, and that is absolutely appropriate. We engage in individuals who are experiencing psychosis, individuals who are experiencing and expressing suicidal ideation or self-harming behaviors or ideation. If there's a family disturbance that could benefit from an outside party coming in to figure out what's going on, and if there's not a criminal component of it, if there's a mental health component, officers will frequently call us to talk through. They're considering placing somebody on a mental health hold, and they're not entirely sure of what's going on with this person. They'll call us to see if we're familiar with them, if we'd like to engage and assess them, and this can just look at a lot of different ways. Basically, if there is a question of what's going on, or if this person has familiarity with CORE, we can be called to come in and engage with that person. If we are not available, what we ask of our officers is that they document that we could have been helpful on that call. They'll put it into the call reporting system that we utilize as a 911 response agency, and they'll send an email to us to let us know what happened, how we could have been useful, and they'll forward the written report to us through our law enforcement systems. They can refer people to us. So we are not available 24/7. We have limited availability at this time, something we're hoping to expand in the coming years, but it's a work in progress. So if somebody overnight engages with somebody who either is a CORE client or could benefit from contact from CORE, we ask that they send us an email with the person's name, identifying information, where we can find them, how we can contact them, the case number of the previous law enforcement interaction that prompted this referral, what happened, whether this individual was informed of CORE, etc. They'll just send an email to us and we will take that and see what we can do to make contact with this person and intervene in the circumstances in their life.
Thanks, Kate. So Kate mentioned earlier that we're all dedicated members of this team. That is to say, every member, whether they're an officer, whether they're a paramedic, whether they're a clinician, they are dedicated to this team full time. They do not, with the exception of Kate, because she has a few other hats that she wears, but our team members are exclusively a part of this team. So they're not pulling myself or Kyle or Garrett or other paramedics off of an ambulance. The officers are not being pulled off a patrol to come do this, for a few hours. This is when we come in, this is what we do all day. And while we are three different professions, we do have overlap with what we do, especially with our training is concerned. We're all CIT trained, crisis intervention teams trained. We all are supervised by a police sergeant as well as a supervisory mental health clinician. Kate, we can go to the next slide real quick. And just to kind of expand on who our team members are, Sergeant Feaster is the team supervisor, and Amber McDonald, Dr. Amber McDonald, is the medical director of the team. We also have our other officers, Taj Petsis, as well as John DiMatteo, myself, Kyle Huber, Garrett Starman are the paramedics on the team. Clinicians are Maeve Whitman, Chris Lingwald, and Kate Origer, who is here with us. So having all of these folks from a very, very diverse background, with different experiences and different perspectives, we don't necessarily have an echo chamber here. In fact, we prefer not to have an echo chamber. What we are able to do is leverage those experiences and perspectives to arrive at an agreement with the clients that we contact to have the best outcomes possible for them. So just to kind of break down what individual roles do on the team, officers are responsible for scene safety. Depending on the circumstances, they will make initial contact with the individual. They will participate in de-escalation, build trust and rapport with the individual, help the individual navigate resources. If necessary, we'll evaluate for safety and determine if this person needs to be placed on hold, if they can't be safe where they're at, or if they don't have an understanding that they need a little bit more assistance with what's going on with them. And again, they address the enforcement side of things as far as whether there are any criminal matters that apply to the situation. Our clinicians engage individuals. Again, they de-escalate folks. They perform a risk clinical assessment. They help navigate resources, determine ongoing needs, and again, if necessary, evaluate for M1. And they will recommend placement and disposition as appropriate to that individual and their circumstances. And with the paramedics, we provide the medical screening. We can do field clearances as appropriate. If necessary, we will administer medications and provide other treatments. We'll determine if medical transport is needed. More often than not, when somebody presents in a certain way, we will try to transport them in the most trauma-informed way possible. Our vehicle is an unmarked SUV. And unless you're actually looking, you're not going to be able to tell that it's a police vehicle. So this gives, a bit of discretion for the individual to be comfortable knowing that nobody's going to look in and see them in the car where they're going. We have tinted windows, and we can comfortably take them to where they need to go while maintaining safety for themselves and ourselves. But there are circumstances where we need to transport somebody by ambulance just based on their presentation and how they're behaving or whatever treatments they may need and what's to the hospital. So we will determine if that's necessary and arrange for that as well. Medics can also participate in the evaluation for M1 process. We provide medical education as appropriate, and we liaise with the fire department or EMS, as well as the hospital departments. And we're also very good at helping navigate resources for individuals that we come into contact with. So again, this allows for a more collaborative assessment and response, and we're not pulling resources unnecessarily from different places. So we're not having to call an ambulance to come in just to do a medical clearance when we have personnel available who can do it right there on the spot. We're not having to necessarily pull somebody from patrol to address any safety issues. And I mean, depending on the situation, it may be necessary, but we don't right off the bat have to do that. More often than not, if we're getting sent to a call, depending on the nature of the call, we'll cancel patrol and handle it ourselves. And our clinicians are able to determine if it's necessary for this person to be placed somewhere, or if in their risk assessment and clinical assessment, they're able to determine that this person could be safe where they're at. And next slide.
Like Omar just mentioned, we do a lot more than just crisis response. That is our primary purpose. We are available by if someone calls 911, they can ask for us, and that is our primary role. However, we do a significant amount after that, and sometimes that can go on for quite a while. So we do follow up after crisis. We try to get back. We try to get eyes on the person in a time frame of 72 hours after our initial call for service involving them, when possible. If somebody was placed on a hospitalization, or if they were arrested, then sometimes it can take a little longer than that, but we do try to provide follow-up for every person that we encounter. We do outreach with community members. We do a number of things just like this. We will do, we'll participate in awareness efforts so that the community knows that we're available as a resource and can be called upon for this wide variety of circumstances that we are equipped to handle. We do outreach and collaboration with organizations. We will do a monthly meeting where we get together with the other agencies in our community to build relationships and look for ways to approach certain circumstances, situations, or individuals that are known to a number of us collaboratively. The follow-up that we can provide. So as Omar mentioned earlier, I wear a number of hats in this department, and one of those is the clinical case manager for this team. So I work alongside the case management that I mentioned earlier, who work on our lead and angel initiative teams. I work alongside them. However, the client load that I carry comes specifically from the core team. They have the mental health concerns that require more long-term intensive intervention than a core team, a co-response team is intended to provide. So sometimes people will be referred to me for longer-term, more intensive support, achieving their goals and addressing some of the concerns that they may be experiencing in day-to-day life. So we have a really wide variety of follow-up options we can do. One of our biggest goals is to build relationships with the community members and the agencies that we work alongside, all with the intent of benefiting the clients that we serve on a wide scale basis. That is all we have for you today. This email address is for our sergeant. Should you have any follow-up questions, commentary, feedback, anything for us after this presentation today.
Awesome. Well, thank you both. While I have a couple thoughts, but while I'm doing that, if anybody in the audience wants to post questions in the Q&A, we can get to those as well. Again, thanks for being here today. It's been so interesting. I don't know that much about co-responder models. I've been reading about them. I'm so interested to hear your presentation today because they've gotten so much attention and they've been growing in the past few years. I work primarily in the VA where we're developing our own co-responder model. They're just sort of fascinating, and I'm glad to learn more about them today. I'm interested, you talked a little bit about this, but what's the distribution of the calls that come into you? So you mentioned people in the community can contact you, they can be triaged to you. How many different ways are there that people can get a hold of the core team at this point? Has that expanded over time?
So there's one direct method for getting a hold of us, and that is still to contact us through dispatch, because
Okay.
we are available for 911 service calls. Different agencies around the community know to call our non-emergency dispatch to get a hold of us.
Okay.
Sometimes they have our direct emails. We try to build these relationships so that we can be available for the needs of our community agencies and partners. But the method to get a hold of us is still through our dispatch.
Sure. Well, the additional method, but it sounds like that's kind of expanded, right? That's really fascinating. There's a lot of work in like social network analysis and how once you start to provide services within communities, sort of things branch out, and again, people learn about one another and these networks build, and that becomes an infrastructure for help ongoing. So that's really cool. There's a bunch of different, like reading before today, there's a bunch of different types of co-responder models, and I guess you can think about who is part of your team. And I'm wondering, how did you decide who was going to be a part of your team? And so you said there's a clinician, a paramedic, and a law enforcement officer. Was that sort of assumed from the front that that's what the team would be of, or was there any discussion about what that should actually look like?
Sure. So the architects of the team, looking at what model they wanted and what they wanted the team to be able to do, right off the bat had decided that they wanted this kind of configuration.
Mm-hmm.
Throughout the state, throughout the country, you will see different models that are what they call true co-responder teams, where it's just a clinician and a police officer, or you'll see what's called a paired response model, where it's a paramedic or an EMS provider with a clinician or a social worker that go to mid to low acuity calls, or if they're summoned as a secondary response by law enforcement to a scene. But with our team, we were looking at what the needs were and a lot of the overlap that's involved, and realized that we needed these three professions. So the architects of the program here recognized early on that this was something that they were going to need in this form.
Sure. Where you mentioned earlier on, sort of really early in the presentation, about like all the different components of this. There's like training, there's de-escalation, all this stuff. Like curious, like what do you think it is? Like when this works well for someone, what do you think the key ingredient of this model is? Or is there a key ingredient, or does it sort of differ based on the situation?
I think key ingredient is having different people and different personalities that could potentially connect with that person. There are individuals that we connect with that will look at the officer and say, I don't want to talk to you. And they'll look at the clinician and say, I don't want to talk to you either. And then they'll look at the paramedic and say, hey, I like you. I want to talk to you. And we've had, where it's been the other way around, and, they don't want nothing to do with the guys in the uniforms, but they'll talk to the clinician all day, or they want nothing to do with the paramedic or the clinician, and they'll talk to the police officer all day. It's really that human connection, and basically just being a good human, and then just talking to people and trying to connect with them. I think that's the special ingredient in our sauce that, really helps us in the successes that we've had.
Yeah, it's so interesting. I mean, it's the same thing in sort of healthcare interventions. You can put three types of clinicians in front of a patient, and maybe they just bond better with one, or they reject one. And sometimes we don't know all that goes into that. Is there something that like goes into the selection of the people who join this team, or do you think that's like sheer luck, that you're sort of crossing your fingers that on any given engagement, that one of the person or more of the people on the team are going to click with the person who you're trying to support?
I think part of it is certainly selecting the right people for the job. We firmly believe in having the right people in the right place for the right reasons. So certainly having, the quality of people that we have that are, providing the services and the roles that they are, allow for greater flexibility and more opportunity to be able to connect with people.
Yeah. Okay. Kate, you had mentioned in sort of at least our email correspondence and leading up to this, sort of the focus on harm reduction in this model. And I'm wondering, for folks who maybe that term isn't so familiar, or isn't so familiar of the intersection between harm reduction and co-responder models, I was hoping you could just talk a little bit about that.
Sure. So harm reduction as a concept is the idea of minimizing the risks associated with the person's circumstances, choices, behaviors, or environment, so that there is some capacity for that person to live the lifestyle that they're choosing in the safest way possible. We see this frequently when it comes to substance use. So I'm going to speak a little bit further to Lead and Angel just to illustrate this, being our case management teams that serve to help people who are struggling with substance use. A big part of their entire program is based in harm reduction, and that looks like offering fentanyl testing strips. Narcan is widely available for distribution throughout the community by this team, educating people on how to use Narcan and what to look for administration. These are facets of harm reduction, and we utilize that in co-response as well, in the sense that being the team that's responding, having a paramedic is one huge example of harm reduction in what we do. We have a medical professional coming with us to engage with anything that may be presenting with this person. We try to divert people from being arrested, hospitalization. We try to engage in a situation in a way that honors and promotes a person's autonomy, self-determination. We use trauma-informed lens, which is a form of harm reduction in the sense that by engaging with a person in a trauma-informed way that is seeking to avoid hospitalizing or institutionalizing a person, we are trying to intervene in the situation in a way that will cause the least amount of, if not none at all, no harm to this person who's already struggling.
Cool. Thank you for that. And I just had sort of one more question. I'm curious, so you've got this co-responder model. It is consists of at least one law enforcement officer. It sounds like importantly, there's probably some selection process, right? Like it's important, as Omar mentioned, to think about who exactly is going to be represented on this team. But then there's a larger question of the rest of law enforcement. And I'm wondering if the development of this model has impacted the way the other law enforcement unengaged officers are approaching some of these similar situations, either because they know of the model, have the model of the resource, or maybe because they know their colleagues are now on the model, or they've learned more. Like, what has that changed the way that the rest of law enforcement, at least in the community, has responded to any of this? Or is that an unknown?
I would argue that I've seen some change. Our officers switch schedules every year. And so as such, they rotate through who has exposure to our team with the hours that we are on.
Okay.
So there are new opportunities every year and throughout the year for our officers to see us, work alongside us, see what we do, see how we do it, and see why it's important that we do what we do. We have the opportunity every 3 months to participate in-service training, where we get to get in front of our patrol, all of them, no matter what shift they work, to, again, teach them who we are, what we do, and why it's important. We offer ourselves as a resource to our patrol in the same way that we offer ourselves as a resource to our community. And we are available to have a conversation with our patrol officers about what they could be doing differently to intervene in a certain sort of situation or circumstances. And I've seen that play out. I've had conversations with our patrol officers that I've seen them take and implement in future engagements with people who are experiencing similar circumstances. So I would say that within our department specifically, having us around and being exposed to us has changed some of the ways that I've seen our officers show up for our community members.
Okay. And to add on to that, I'd like to share that, especially with our lateral transfers, that is officers who have previous experience with another agency, when they come into this department, I've noticed collectively a great deal of excitement over us having this program and having it available for the community. And they immediately latch on and they will tap us for info and, guidance and information and kind of talk to us about different people that they've come across as they, work patrol. And it's not just patrol. We have people from detectives that'll come talk to us. I've had traffic officers come talk to us because of people that they've contacted, animal control. We've had a variety of people throughout the department, and not just I don't want to exclude fire because fire department has also come to us regarding several individuals that they've contacted that, hey, just can you guys reach out to this person, see what's going on? So being present and doing what we're doing and kind of seeing that excitement and recognition grow, and seeing that people want to utilize us both internally and externally is really something that gives us a lot of pride.
Omar, why do you think that is? Why do you think that lateral transfers seem to have a lot of enthusiasm?
Without speaking for them per se, I think that given that this is not something that's in this particular format everywhere, having that resource available that can help mitigate, all these different types of these calls for service where there's a behavioral health component is an extra tool in the box for them. And I think in their eyes, it helps improve outcomes for these individuals. So.
Okay. All right. Well, thank you both. I appreciate you being here today. And thanks for offering your contact information for anybody who wants to follow up. And with that, that'll conclude today's webinar. So thanks for being here, everybody.
Thanks for having us.
Okay.